All right, it is right at 5:30 and we love to start on time. So welcome everyone and good evening. We are so thrilled that you have joined us for our Ask the Experts webinar series. And before we get started tonight, I wanted to make a few quick announcements. First of all, if you missed our previous webinar, you can catch those recordings on our YouTube channel and on our website. So if you go to YouTube and look for Urology Austin, you will see our Ask the Experts webinar series. And you can also visit urologyaustin.com. Under patient information, you will find all of the information about our past webinars and our future webinars. The last webinar is a topic that I know many of you will be interested in. It was around erectile dysfunction and really discussing solutions beyond Viagra, as well as informative information on Peyronie's disease. So you'll definitely want to go and catch that one for sure. So just a few specifics about the webinar tonight. It's a very simple flow. We're going to walk through a presentation for you, and then we'll end with Q&A. And throughout the presentation this evening, feel free to submit your questions using the chat box. You'll normally see that at the bottom of your screen, and we'll collect those as we go through the presentation this evening, and then we'll be able to jump into those questions at the end. Definitely don't be shy. Record those questions, send those over to us, and we'll address those at the end. And then as you close out the webinar this evening, you will have an opportunity to submit a survey, and we would love to hear your feedback. It just helps us to be able to continue to improve our Ask the Experts webinar series and provide content that you truly enjoy learning about. Well, let's get started. I would love to introduce Dr. Garbett, our expert for the presentation tonight. And we are going to, he is a board certified vascular and interventional radiologist with over 15 years of experience. He's internationally recognized and as an expert in his field, and you can also often catch him as a co-host or guest host of the Back Table podcast. He has a few very special interests and expertise areas. Those include prostate artery embolization, or PAE, hemorrhoid embolization, or HAE, joint embolization for joint pain, and varicocele embolization. So welcome, Dr. Garbett. I will let you take it from here.
All right. Thank you so much for that introduction, and welcome everybody. Thanks for joining us here tonight. We hope this is educational for everybody. And thank you for the introduction. So I like to throw out this, we're talking about prostate artery embolization. And, you know, in my field, this is ubiquitous. This term embolization, we just take it for granted. But every time I talk to a patient, this word is a confusing term. So I like to start out with a definition. And every time I see a patient in the office, this is where I start. So embolization is a minimally invasive procedure. We use it to block off blood vessels that may be abnormal, or they may be feeding different areas. So we use this procedure to treat things like benign tissue growth in the case of the prostate, or in cases of a uterus. There are cancers that are treated this way. Aneurysms are treated this way. We can use it to reduce inflammation in the joints and many other things. So that's just a preface on that. Where are we going today with this? We'll start with what is BPH, benign prostatic hyperplasia. We'll move on to the procedure itself, the prostate artery embolization, and we'll talk about some of the other alternatives as well. And then we'll go over expectations and questions. This is a picture that I use in my office. Mayo put this out in their publications. If you can see my mouse here, you see that up above is the bladder and below is the prostate. Through the prostate travels this urethra. That's the channel through where the urine is traveling from the bladder down to the penis and exiting. In the normal situation, you have a nice open channel, everything's fine, and generally into your 20s, everything's going great. as we age, our prostate can enlarge. And so you can see here, if you see where I'm passing this arrow here, the prostate's gotten so enlarged that it's pushing up into the bladder. The urethra is narrowed. And so that's going to result in all those problems that we see with the enlarging prostate. If we have any engineers on the line, we're here in Austin. We have a lot of engineers. They love this equation, the flow equation. So if we narrow the radius of the diameter of this channel, the urethra, it's directly proportional to the radius cubed. Now, this is just for the engineers. So if we double the radius by treating your prostate and widening it, we increase the flow by 16 times. The reverse is also true. If we narrow it by half, we reduce the flow by 16 times. So that's what happens there. And everybody wants to know, how big is my actual prostate? So when you're young, your prostate's generally small, about 20 cubic centimeters. As it gets bigger, this was published in the journal Urology back in 2001. They just helped equate this for patients. So where do you fall? We consider 30 starting to be slightly enlarged. That's about a ping pong ball. And you can see it just keeps going. A lot of men are in this range here, 65, and then it can keep going. There is no limit. We see people with prostates of 150. We see people with prostates of 300. The symptoms don't always match the size, but generally it does cause some degree of blockage. How common is it? You know, there's things that people talk about and there's things that people kind of avoid talking about. Interestingly, a lot of men just don't talk about this. Nobody wants to tell, their friends, hey, I have trouble peeing. But it's so common. Seeing this graph, you can see how common it is. By the age of 50, some studies show that about half of men at 50 are experiencing symptoms. But some others say about 25. But certainly by the age of 60, at least half of men. By 70, 75, by 85, almost every man has symptoms of this. And why is this important? So there's a ton of men with this. That's the thing. And it's something that doesn't have to go untreated. We have medications that can help. We have treatments that can help. But what's going on? So generally, any kind of procedure that you want to have done, let's say it's a hip replacement or it's a treatment for your prostate, we're all worried about having side effects. And so 54%, according to one study, is the number of men who avoid having any kind of treatment for fear of side effects. So that's why we're doing this sort of thing, to help people understand these kind of treatments. So how do we decide who needs treatment? We look at your symptoms. Now, the bladder has to store it and it has to push it out. And so we kind of divide it into those symptoms. If you have the irritation symptoms, you're going to go more often. You're going to have to go urgently because it's sort of a surprise. You're going to have to get up in the middle of the night to go. And you might feel like you need to go and then it just comes out. That's the irritation symptoms. And then there's blockage symptoms. This is the stream getting weaker over the years. You used to be able to go to the urinal and stand back a little bit, and now you kind of have to get really close. Or if it's the toilet, the same situation. Waiting a long time to go, trying to push your belly to try and push it out, dribbling, all these sorts of things. We generally assess this it's subjective, but this is called the IPSS scoring system. The little tongue-in-cheek with the IPSS, right? So generally, we give this out, mental circle where they fall on all these things, how many times do they feel like they're not emptying all the way, if it's cutting out in the middle of the stream, if you're having to go urgently, if you're getting up at night, and then how satisfied are you with things. When we total these all up, if you fall into the moderate category or the severe category, it's certainly time to think about a treatment. And generally, we'll start you on medications just to see if those will work. And then there's quality of life. If you fall into the mixed or mostly dissatisfied as far as how your symptoms, deal with your life, then we're going to think about treatment, even if you fall into the mild category. These are some of the treatments we have. This is Urology Austin. We have tons of different treatment options. They're all great in their own way, and sometimes just finding the right treatment for you. Urolift, this is where these clips are placed into the urethra, and they'll kind of widen the urethra you see there. This is the prostate artery embolization, which we're going to go in more detail. Resume, which is another treatment, and then aquablation. The next slide, I'm going to show you a couple little animations. So this is the Urolift. A tool is inserted through the urethra, and then these clips are inserted. You can see how it kind of widens that channel. This is the Resume procedure. Another tool is inserted into the urethra, and then a small tool travels from the urethra into the tissue of the prostate gland, and then steam is inserted to help reduce the size of the prostate. This one is showing the aquablation. A catheter is inserted into the rectum that performs an ultrasound. That ultrasound is used to guide this power washer, basically, that's going to carve tissue off the prostate. This is useful for very large prostates, and in certain situations is the preferred method. This is just the diagram of the prostate artery embolization. I'm going to show you a video that's going to make this move, and it'll make more sense. But basically, this is the only procedure where we go through the artery rather than through the urethra. So in this procedure, there's no need for a catheter in the bladder. And you can see that we're able to, well, you'll see on the video. So I'll wait for that. But you can see the large prostate, and then it's shrinking after. I just hit this again. I like it in there twice because even though we go over it, everybody forgets half of what they learn within 10 minutes. So embolization, this is a minimally invasive procedure that we use to cut off blood flow to certain things. We can use this for many different purposes. Now, this is going to be, I'm going to kick out of that for a second to go to this video. And here we go. So you'll see a small tool is inserted into the artery here after it's anesthetized. There's no nerves in here, so the patient can't feel this. Small tube is inserted, and then an even smaller tube. This tube is about 1 millimeter in diameter, very, very small, traveling through the artery. We find the artery to the prostate. We inject tiny, tiny beads. They're 200 micron in size. And then you can see how we're able to treat both sides of the prostate. Your prostate has 2 hemispheres, just like your brain. So we go down there, treat the other side. And then once that's done, we're able to remove our tools. That small hole is about 3 millimeters that we put in the artery. Once we're done, we insert a small plug over the top of the artery that will help it heal quicker so that we're able to get you out. So now we'll pop back into this. Give me 1 second here. Okay, this is another video. This is an actual, so this is not the cartoon version, but the real version. You can see in the top left-hand corner, the physician is over here. They're accessing an artery in the wrist in this case. We usually use the femoral. But this is going to be sped up about 20 times. So let's get this going. So they're taking a picture of the artery, and you're going to see it flashing on and off. They're going to make a road map, we call it, of these arteries. If you do thousands of these, you know that this squirrely guy here is the prostate artery. You're going to see them track this tiny wire down into there. Once they're in that artery, they're going to inject a little contrast. This is basically liquid that goes in the artery that we can see on live x-ray to confirm prostate. Those of us that do this know this is what a prostate looks like. And this is about 100 cc prostate. How do we know when we're done? A lot of people ask. So we mix the beads with contrast. And just like when you're filling up your cup at the sink and you see that it starts to get full, we can start to see that the flow is slowing down. We know we've blocked enough. You can also see the prostate starting to get stained, we call it, with the contrast. So once it's full, the video ends there, but we'd pull back and go to the other side of the prostate. Now what happens So that was sped up 20 times. This procedure, basically, when you come in, we get you in a gown, we put an IV in your arm, and then we give you a Valium. I'd say for about 80% of patients, that's all you need. Most men fall asleep just with that. The procedure itself is painless, so it's just about keeping you comfortable and not bored for a whole hour. Generally, we'll throw on some country music, or if somebody asks for something, we'll put something else on. But yeah, it's about an hour, sometimes 30 minutes, sometimes 90 minutes. After the procedure, you go to the recovery room, hang out for so we have 3 different little plugs that we use depending on the situation. One plug is 30 minutes, one plug is an hour, and one plug is 2 hours. During that time, we'll keep your access leg, usually the right leg, straight. That area where we went in the artery can be sore for about a week or so, and that's normal. We don't want you driving after the procedure because of sedatives, so you do need somebody to take you home, and we prefer that to be somebody you know, not an Uber driver. I know in some cases it's hard to find somebody. And then we don't want you lifting anything heavy for a whole week. We want you to heal up real well. 15 pounds or 2 gallons of milk is what I tell people. If you've got golf stuff, tennis stuff, if you're going to the gym, just hold off for a whole week. And if you're one of my folks who lifts weights, if it's 100 pounds, 2 weeks. What do we expect after the procedure? So the treatment will irritate your prostate, usually for about a week. And what does that mean? That means you may have some burning when you pee, you may feel like you need to go more often, and you may not empty as good as you usually do. Usually lasts a week. Occasionally it drags on a little bit longer. We give you some medications to kind of smooth that out. So how long till you start to feel some improvement? Generally about 4 to 6 weeks or about a month. We do the treatment. It does take a little time for the prostate to really start shrinking. So generally about 4 to 6 weeks. And usually you'll start noticing the flow is a little faster. You may not be going less often yet. After about 2 to 3 months, we expect that you're not getting up at night to pee anymore. Generally, we'll stop those prostate medications at that point if you're doing really well. And then those other symptoms toward the end, like having to go really urgently or surprise urination, those things will improve it around the end of that. How long does it last? Typically about 5 to 10 years. We see the average is kind of about 7 years, and it is repeatable. So if you're in the younger end and a decade is still, you're on the younger end still, you're probably going to need more help. And so we can certainly repeat it down the road. It does work over and over again. And it doesn't block you from having any other procedures. So if an aquablation or Resume is more appropriate 10 years from then, that's totally fine as well. And if something new comes out, that's an option probably too. What are the problems that we see? So the problems, the risks. We do about 100 of these a month, and we do see about 1 person every month that gets a bruise over that artery site. We call that a hematoma. And it's not just a little tiny bruise. It is about a bruise about the size of your hand that looks like a black eye in the wrong place. That's going to take about a month, maybe 2 months to go away, depending on how quickly you heal a bruise. But it's basically just cosmetic. Doesn't hurt generally, and it takes a while to go away. Retention. So what is this? There is some irritation after the procedure we talked about. Very, very rare. So about 3 in 500. That irritation after the procedure is bad enough to where about 3 days after the procedure, you're just having trouble emptying. And so everybody gets my cell phone after the procedure, and I encourage everybody to call me if there's any questions or problems. So about every few months, I'll get a phone call from someone who's, they've been trying to pee for about 4 hours, and they're just dribbling. What do we do? So you call me. I make sure everybody that's in this category, not everybody's at this risk category. If you're in this category, I'm going to tell you to take 2 Flomax pills or tamsulosin, same thing. I'll tell you to take 2 of those, wait 2 hours, and then call me back. Usually takes care of it. If it doesn't, if it's business hours, we'll have you come in the office. We'll put a catheter in. You can keep that in for about a week until the inflammation's gone, and then we'll take it out. Again, this is very rare. I've had, done thousands of these, and 12 patients total have needed a catheter. And then this non-target embolization. So the target is the prostate. Non-target means something else. Your prostate shares a little bit of blood flow with the bladder, which is right above it, and the rectum, which is right behind it. It also shares a little blood flow with the skin nearby. And so if we get a little bit of those beads that we inject, if a little bit go to the bladder, you may get a little bit of bladder spasms for the first week or so. If a little goes to the rectum, may have a little bit of spasming in there as well. Again, not common, but it usually resolves in about 3 weeks. If it goes to your skin, it's going to block blood flow to a small area of skin, usually about the size of a quarter. And so what does that mean? You get a skin sore. And where can that be? It could be anywhere in the area of the groin. So that could be on the buttock, on the anus, on the penis, on the scrotum, on the groin skin, any of it. So very, very rare. Again, I've done thousands of these. I've seen two patients who've had a skin ulcer. Takes about 3 weeks to heal and hurts like a burn. So it is rare, but I want everybody to know about it. People may have questions about these. I went ahead and threw these in because these are kind of high points for questions. Blood thinners. So one of the special things about this is that you'd think we're going in an artery, that bleeding would be a problem and that we couldn't use blood thinners. It's exactly opposite. Blood thinners are totally fine. We generally do stop them for 2 days just for our own protocol of safety, but it is totally fine to continue them if it is necessary to stay on them. And then catheters. A lot of people have this question, are you going to put a catheter in my bladder? Because a lot of the other procedures, that is the first step. In this procedure, we're not putting a catheter into the bladder. If you do happen to have a catheter, we do treat some folks who have a catheter, and the goal of the treatment is to get the catheter out. So if you're coming in with a catheter, we're going to leave it in for a month and let the prostate shrink for a whole month and then take it out. All right. So I guess we can turn it up to questions.
Yes, and we have several. And I believe
Excellent.
at the top of the webinar, I said to use the chat feature. It's actually the Q&A feature, so you can put your questions there. All right, so we have several, which is great. Keep them coming. One question, Dr. Garbett, is does BCG treatments interfere with the treatment? Oh,
good question. Yeah. It does not. We treat a fair number of folks with bladder cancer who are having those treatments. We do work on timing, though. There are some timing considerations. Generally, we're going to wait until you're done with the course and you're on a gap time before we're going to treat your prostate. But we can work around that. The urologists, whoever your primary urologist is, they'll know that timing and help us work through it. But good question.
Another is, does drinking some wine at night negate the benefit of the treatment?
Also a good question. I tell people, we talk about coffee and caffeine and alcohol and beer and wine. These things will make you pee more. So as long as you understand that expectation, if you're going to have a coffee or if you're going to have some wine at night, you're going to pee more and you're going to have to just get to the bathroom more. There's nothing wrong with that. I do recommend, at least for that first week after the procedure, not to do it because there's inflammation and we don't want to end up getting things too irritated. But yeah, that is a good question and that's fine.
Another question here, you may have already hit on this, but what are the qualifications for the treatment?
Here we go to the little screen. Qualifications, so I did not really cover that, I guess. Mainly that you have BPH, benign prostatic hyperplasia, so enlargement of the prostate that's causing you symptoms. And the symptoms vary, we did cover them a little bit, but basically having more difficulty going to the bathroom, difficulty emptying, and that you have an enlarged prostate. There are some circumstances where we'll treat folks with almost normal sized prostates, where the prostate has kind of grown into the urethra rather than growing out. But those are, I think those are less common. So we do treat, we treat folks with BPH and symptoms who are, the whole spectrum, 30 cc's up to 300, 400, 500 cc's. I hope that covers it.
If it didn't, throw another question in. We have several questions, so I'm going to try to run through as many as we can. Does the procedure hurt, and how long is the recuperation period?
Yeah. So the procedure itself is painless. There is a moment, you have a Valium, so you're already kind of relaxed when you get back to the procedure. Most men are snoring by that time, but not everybody is. And we give you a little lidocaine shot right over the artery. It stings for about 10 seconds. Then it's all numb. And the only thing you feel after that, if you're slightly awake, you might feel some warmth every time we inject the contrast because it creates a warm sensation. Recuperation, it's really just that generally 30 minutes to an hour in recovery with us, and then off to home. And then if you're thinking about like, when can I return to normal activities? I do give you that lifting restriction of no more than 15 pounds for a whole week to let the artery heal, but you can be up and about, you can go shopping, you can drive your car the next day. If there's workouts or sports, I want you to hold off on that for a whole week, for 1 week though. It's not very long. If the question is also, the question might also be how long till my urination symptoms are better. That's a little longer. That's a month to 3 months.
I think this is a great question. Is the procedure, if the procedure is done at age 67, say, does the prostate continue to enlarge? And if so, could the procedure be performed again 10 to 15 years later?
Yes, good question. So yes, so what happens, the prostate will shrink, and it will shrink for about 6 months. We know from long-term studies that it shrinks for about 6 months, usually about 40 to 60% size reduction. So if it's 100, it might end up at 40, it might end up at 60 cc's in size at 6 months. After 6 months, the prostate has remade all its blood flow. The prostate's very durable. And so it will remake its blood flow. It will start to grow again. It generally takes about 5 to 10 years before it's going to cause problems again. And then, yes, the procedure is repeatable. There's technically no limit to how many times we can do it. I've treated people as young as 44 and people as old as 101. And the 101-year-old, just for fun, his only question was, will I still be able to get an erection? And I said, if you can get an erection now, you'll still be able to get it after.
Amazing. All right, another one is, do arterial stents make this procedure impossible to perform?
Good question. So vascular disease is common in our the increasing age group, especially in folks with diabetes. These things don't prevent us being able to treat. I will say it can make the procedure a little more fun as far as finding your way to the prostate artery, but no, it doesn't prevent. Knock on wood, I still have not had a patient who I was not able to treat.
This one kind of goes with your prior comment, but is there any risk of impact on sexual function?
Very good question. So the official answer is really not. There are some studies showing improved sexual function, but I think those are probably, so it's colored by something. This is not a treatment for erectile dysfunction. This is not a treatment to improve libido or any way in sexual function. But if you are getting up 3 or 4 times at night, or 5 times at night, or 6 times at night to urinate, your libido is going to go way down, and your ability to get an erection will go with it. If your bladder can't be fully emptied, it can be very hard to get an erection. Now, fixing that will not always improve sexual function. So we do get a lot of questions like that. Will this improve my sexual function? What I tell folks is it will not, but if you can sleep better at night, you may. Yeah.
This is a question in terms of the post PAE and travel. So what are post PAE limits to take a 3-hour domestic flight?
Good question. I get this question a lot. So what I do recommend, and not everybody listens, is to have the procedure and then don't travel for a week. That doesn't mean you can't travel for a week. You know, the treatment will irritate your prostate and your bladder for usually about a week. And so that can mean that you're getting up to pee more than you do now. So if you're on an airplane and you got to get up every 20 minutes, it's going to be terrible. It's going to be the worst flight of your life. So, but I have had plenty of patients who'd go and do it anyway. I just say, make sure you get a bathroom seat, you know, right next to the bathroom. So it's not you can't do it, but I don't want you lifting more than 15 pounds. So again, if you got a 50-pound luggage, that could be a problem. But if you're going for a long drive, that's fine.
All right. Another is incontinence a possibility?
So the quick answer is no. But the more complex answer is if you have a neurologic condition to start with, something like multiple sclerosis, which is fairly uncommon, or very severe diabetes, either of those conditions does some nerve damage to the tiny nerves of the bladder. And so in those cases, and there may be people on the line with MS or a neurologic condition, Parkinson's, for example, in those cases, there is decreased ability to regulate the bladder. And so less related to the prostate. So in those folks, a larger prostate actually prevents you from leaking. And so sometimes we'll have a conversation with those folks that, you know, we're going to make it easier to empty, but you're probably going to be leaky. Now, this is not a problem with folks with normal neurologic function, but it can be a problem if you have severe diabetes or if you have multiple sclerosis or similar condition.
Well, this is a question that several people have asked. Is the procedure covered by Medicare?
Good question. So I forget, I think it was in 2021 when Medicare put this on their coverage list. So it is covered by Medicare. To put a caveat to that, it is covered by Medicare, but if you're on a Medicare Advantage plan, such as like, you know, a plan that's managed by United Healthcare or Aetna or any of the big healthcare providers out there, they have a process called prior authorization, whereas Medicare does not. And so if you're in Medicare, it's covered and we just schedule you. If you're on any of these private insurers and an Advantage plan, which is also Medicare, but it's an Advantage plan, then it requires prior authorization, and we do occasionally see denials with them, but we're usually able to overcome them if there is a denial, because it is covered by Medicare.
Do we need to take anesthesia for this treatment?
Good question. Oh, and I don't think I really pushed on this. So it is done in the office. We have little operating rooms in the office where we do it. And so what we do is called moderate sedation or conscious sedation. These are synonymous terms. It's not general anesthesia, so you don't go unconscious and then have a breathing tube. That's not part of this. So basically, you could think of it like light sedation. We generally give a Valium pill after you get in a gown and get the IV in. For most folks, about 80%, that's all you need, and you're snoring through the whole thing. For the other 20% of men, sometimes they're trying to tell jokes or asking me too many questions, and my nurse will raise the syringe up in the air and say, "You want a little bit?" and we'll give you more to make you less awake.
That makes sense. Okay, a few people have asked this question about having prostate cancer. Is it okay to do the PAE?
Good, also a good question. And yes, I can elaborate on that a little bit. So we deal with a lot of patients with prostate cancer here at Urology Austin, and in general, you know, it depends where you are in the process. There's a good spectrum of prostate cancer disease. You know, Gleason 6, Gleason 7, Gleason 8, Gleason 9? And then do you have metastasis? Are you having radiation treatment? Are you having your prostate removed? So we look at all these things. And generally, once you're diagnosed with prostate cancer, we have a prostate cancer conference with your urologist to discuss your whole treatment plan. And you meet with them, and you may meet with me, and you may meet with the radiation oncologist or a general oncologist to discuss all this stuff. We make a big plan. For a lot of folks, that plan, if you have a really large prostate or even just really bad symptoms from blockage, in addition to having prostate cancer, we will often offer you a prostate embolization before undergoing cancer treatment. So it is in the word we use, algorithm. We offer it up front to help prevent your blockage symptoms from worsening once you can undergo treatment.
Well, I see several people asked questions about, is it possible for the beads to migrate to other organs besides the bladder?
Good question. So the way this is done, there's kind of two questions to this. So migration, once they're in there, can they move? And the simple answer is no, they cannot. So they're sized a certain size. We use them specifically when we inject them. We're injecting them from the artery that goes into the prostate. Well, just like a tree and a tree trunk, and you go out to the smaller and smaller branches. As those branches get smaller and smaller, eventually you reach so small that the beads can't go any further. We size them, we use a size of 200 microns specifically for that purpose, so they're stuck. So they don't migrate after we put them there, but can they go somewhere that they're not supposed to go? We call that non-target embolization, and it's uncommon, but it does happen. For the most part, it's fairly inconsequential. A little bit of beads go to the bladder. You have a little bit of bladder spasms. A little bit go to the rectum. You have a little bit of rectal spasms. That generally lasts a couple weeks and goes away. But if it goes to the skin, I think I touched on it before. If it goes to the skin, you can get a small skin sore, usually about the size of a quarter, that will take a few weeks to heal and be kind of painful.
People will ask too, what is in the beads? What's inside the beads?
Oh, good question as well. So this is a fun one because I get some engineers that love to know all this detail. The beads are made of polyethylene, which is your most basic plastic. Unlike commercial products where you may have polyethylene and then other additives like phenols and stuff to give them different properties. These are medical grade, so it's just straight up polyethylene that's sterile. It is plastic. That is your most basic plastic. So folks that are, concerned about microplastics, you're probably getting more plastic in your Tupperware every day, or your plastic bottles. Generally, the volume of these going in is about 1 milliliter, which is pretty, but it takes very little of these to block off the prostate. But it is polyethylene.
Here's a question that might be on the minds of many. I have a beard. Do I need to shave before I have this procedure?
I'll answer that extra. You do not have to shave your beard. That's fine. But we might have you shave down there. It's optional. We can do it or you could do it. And we'll give you instructions.
All right. Let's see. We've touched on so many of these, but here's an interesting question. If you have Alzheimer's and incontinence, will this make things worse?
So we do see this. In those folks, we have a longer conversation, usually with family members, about what is the more bothersome problem. Is it because they're usually incontinent, right? So is the problem that we're going so often, or is the problem that we're running to the bathroom? And so in general, I would say that we do usually opt to treat, knowing that they're still going to be wearing like a Depends type thing, but they'll be leaking less often. And so we may be able to get into the bathroom in a better manner it really depends on the person's situation. You know, how bad is the Alzheimer's? So it's very personal, and we talk about it.
So this question is about, I mean, I know this is one of your specialties, but is this procedure done by my regular urologist?
Good question. So while the urologists have many procedures they do, procedures in the arteries, generally not. So once we get into the arteries, you're looking at a specialist. You know, if it's your heart, where they do a heart cath, you're looking at a cardiologist. My specialty, I'm a vascular interventional radiologist, and the niche thing about that is that we do those sort of like heart procedures, but for the whole rest of the body. And so this procedure is probably some people in my field say this is the most difficult or most complicated procedure to do. But if you do it over and over and over, you get very good at it. It would be very hard for a urologist to learn to do arterial procedures as the baseline, and then they would have to go back to training, basically. So we work together, you know, just like we have radiation oncologists who work in our practice as well. And then we have a pathologist in our practice who just looks at all the slides when we do biopsies. So we've kind of separated all those things out. Yeah. So it would be me as the vascular interventional radiologist, or my partner, Dr. Narayan, who's also does what I do, working with your urologist.
What determines the choice of procedure? So between PAE and aquablation?
Yeah. So this is also, you know, I encourage everybody to speak with their regular urologist to look at all these options. So I only do this procedure for the prostate. I don't do an aquablation or the, resume procedure or the urolift. And so I lack the insight. I lack the really deep insight that your urologist will have that does those. And even among urologists, not everybody does aquablation. So people have kind of subspecialized in those different things. And so I would encourage you to talk with your urologist about those procedures as well to get more detail. You know, a lot of folks choose to do this procedure because maybe they don't want to have a urinary catheter after the procedure, or the recovery is quick, or they don't want to have general anesthesia. For a lot of folks that are in their 80s, general anesthesia may not be an option for them. And so this procedure, because we don't have to do general anesthesia, it's still an option. Or they're on blood thinners, this is still an option. Or, you have symptoms way young, like 45, and you're looking at, I'm probably going to have multiple procedures over many years. This ends up being a great option for a number of things, a number of situations. But I think talking with your urologist who has, an immense experience with all these different options is the best course.
All right, we have another question. I am 51. What is your experience on the best method to approach first? My prostate is at 65 to 68.
So that I would say it's still a discussion with your primary urologist, but PAE is certainly an option for you. Effectiveness, you should look at effectiveness when you're that young. Something like the standard old TURP, which has been around for 70 years, it has near 100% effectiveness. The prostate embolization is about 92% effectiveness, meaning that 92% of patients who I treat will see a great improvement. About 4% will get mild improvement, but not as much as they were looking for. And about 2% may not get any improvement. And so if that's an acceptable, percentage for you, then I think that still works. A lot of folks will look at this as, hey, I can have this done. My recovery is super quick. If it doesn't work, I can go on to have one of those other things maybe in a few years. I see that a lot with younger folks.
Well, it seems like we have a lot of people focused on exercise on
Ah,
the webinar today, which is good.
yeah.
We've got some more specific questions about exercise and waiting for that after. So a couple of them are asking, hey, I'm an avid cyclist, a swimmer, I'm a runner. Is it necessary to stop after the procedure, and for how long?
Yeah. So with we can drill down on each thing, but I think that it's easy to generalize that for the first week after the procedure, I don't want you lifting anything heavy because there's sort of like a little plug that's helping that artery heal. If you exert yourself more than just walking or lifting something not very heavy, you can make that artery not heal well, cause a big bruise, and so, or even some bleeding from that artery. And so it's very important not to lift anything heavy. And so for golf situation, I tell folks, go play your short game for a week. I don't want you doing drives. For cycling, most cyclists that are asking this question are serious cyclists. And so they're doing a hardcore workout. I don't want that. So no hardcore workout on the bicycle. Swimming, we don't want you submerging that artery site for 2 days, but really a week is better to let that skin heal, make sure you don't get an infection. And swimming, if you're swimming, you're probably doing hard work, so a week. What other sports did we have there?
Pickleball.
Pickleball. Oh yeah, pickleball. Most pickleballists I know, and I play too, are running around that court. So a whole week, unfortunately. Um, let's see. Any other sports?
I was looking here, running, but you covered that.
Yeah.
Yeah, the elliptical, which
Oh
is,
yeah. So this is lower impact. If you're truly doing a low impact elliptical, I think that's fine. Um, you can kind of judge your body a little bit on that, but I do recommend just walking for a week if you're doing the elliptical, because walking is fine. People will ask about stairs. Stairs are fine.
mm, all right. Well, you alluded to this during your presentation. You gave a sort of a comical story, but is this suitable for an 80-year-old?
Absolutely. I would say we do tons of 80-year-olds. Yeah.
Let's see. I'm just kind of scrolling. We had over 99 questions. So
Holy cow.
we have just a few minutes left. So I assume we can take a few more, but how are you feeling on the questions and time, Dr. Garbett?
I can keep going. I'm here for the night.
Okay. Right. There were several questions about the procedures versus medications.
Mm-hmm.
You
I didn't really touch on it much. Um, did they ask anything specific, or I can just go into it?
are the procedures something you would have the procedure plus a medication, or is it in lieu of certain medications, a better option for medications
Okay, yeah.
for
Yeah, we can
treatment?
go into this a little bit. So, medical treatment for BPH symptoms, we have a few options. There's Flomax type medications. These are medications that relax the bladder, the sphincter, which is the bottom muscle of the bladder, to allow flow. And so that's one category. The other category is hormonal, finasteride type medications. These block testosterone and help shrink the prostate a little bit. Um, and so in general, if you can tolerate medications, and what mean by tolerate is there's side effects to those medications. So hormonal treatments like finasteride will have side effects that can affect libido. It can affect hair growth. It might give you better hair. It's a treatment for hair loss. But it may also cause skin problems and sexual function problems. So a lot of men want to avoid that, especially if they're younger. If you're in your 80s and you don't really care, those are fine options. And so when you see a urologist, we certainly give you options of do you want to start medications? Flomax is very common to start because it will help a lot of folks at least get further down the road if that's tolerable. But Flomax has side effects. It can drop your blood pressure. If your blood pressure is low already, you may get lightheaded and fall. If you have heart conditions, Flomax you might not even be able to take it. There's other medications like Cialis, which is actually for erectile dysfunction, but also helps with BPH a little bit. A lot of folks start with that, and you may get a little further down the road with that. And then there's a new category of medications, the beta-3 agonists, Gemtesa, Myrbetriq. You may have seen these commercials with the little bladder running around on the TV. These work on sort of those irritation symptoms of like, oh, I have to go to the bathroom too frequently, or, ooh, I have to run to the bathroom. Those will help with that. And so this is where it's great to work with your urologist to kind of figure out the right medication that might work with you or help you get further down the road. But if any of those side effects are intolerable, interfere with just, this is all about quality of life. So if any of those makes your quality of life worse, then if you just didn't do the medication, then maybe treatment is better. And so it is a personal decision. And I have these conversations here and there as well. Usually people have already decided by the time they see me, but not always.
So I have a question about someone having a pacemaker, and does that impact the visualization to inject beads?
Good question.
Any impact?
That is totally fine. In addition to pacemakers, some folks will have a nerve stimulator where there's a device down in the pelvis, and those are fine. They can, it's sort of like peekaboo. It can block my view a little bit, but we just change the angle, and we can see around these things. So no big deal.
All right, let's see what we haven't covered here. A lot of traveling, exercise questions. Yeah, I think we've covered quite a few of these. Age questions. And there's some questions around, again, the symptoms to really pay attention to determine if they should come in for a consultation.
So I think if men are thinking about it, if you're thinking about, should I have a treatment? That probably means that you've got symptoms that are bad enough that you're already thinking about it. So I think at that point, if you're thinking about it, just come on in, have a consultation. You can consult with me as your first stop, but I do recommend you consult with your primary urologist as your first stop, because they have, I have one tool. They have many tools. So at least, come into the guy that has the whole toolbox, but you are welcome to see me first, and I can certainly make recommendations.
That is definitely several questions is, do they make appointments directly with you, and how far out you're scheduling procedures, and where is the surgery done?
Oh yeah. Let's see, appointments first. Just to reiterate, I do recommend you see your primary urologist first to discuss these things. If you don't have a primary urologist and you're just, you're getting on this because somebody told you about it, I would suggest you still go see one of the primary urologists first to get all your options and laid out in front of you and talk about medications and everything. If you're really just already decided, we can move to me first, but I'd still prefer you go see your urologist first, because we do all that testing first. We check to see how big your prostate is. We look at all your symptoms. We discuss medications, and that's better done with your primary urologist. So that's the appointment. I lost track. What were the next things?
How far out?
Oh, scheduling.
Schedule.
Yeah.
Yeah.
To see me, if you're just coming to see me, have a consult, that's pretty quick, a week or two. If you are trying to book a procedure, I have a partner as well, Dr. Narayan, And between the two of us, it's usually about a month or two. I'm probably booked out a little further because I've been with Austin Urology longer. So it's probably about a month to 2 months to get on the regular schedule. We do get cancellations and reschedules, so spots open up. We try to reserve those more urgent spots that just popped open for folks who are maybe going to cancer treatment after, or they're spending 6 months in another country, and so they're kind of stuck for time. These are all options.
Yeah. Are there, as we kind of wrap up, Dr. Garbett, are there any questions that you often hear that we didn't cover tonight, or did everyone pretty much hit on the most popular?
I think we hit on the most popular ones. I think the blood thinner one, I mentioned it in the talk that, if you're on blood thinners, that people might not ask it. If you're on blood thinners, we generally stop them for 2 days prior. If it's Coumadin or warfarin, we stop that 5 days prior. If you are very high risk of having blood clots or very high risk of stroke because of other health conditions, then we'll probably just continue your blood thinners, because the risk of having a bruise is much smaller than the risk of having a stroke. And so in those cases, we'll just continue your blood thinners.
Great. Well, I think we can wrap up for the evening. Several people have thanked you for your time, Dr. Garbett, and it has been super, super informative. Just for everyone, you can obviously call and schedule. So you can visit urologyaustin.com and schedule online to start with your urologist. And then Dr. Garbett's scheduling number is 737-241-2184. We thank you all for your time this evening, and we look forward to our next webinar. Thank you so much for joining.